CataractCoach.com, podcast series, episode number 62, with Dr. Kendall Donaldson, building a successful ophthalmology clinic and practice. Welcome back to our Cataract Coach podcast. And today I have a very special guest, Dr. Kendall Donaldson, who helped establish a new satellite for Bascom Palmer implantation. We'll get her input about academic ophthalmology and how that's been for her, what it was like to set up a new satellite basically from scratch and build that over the years. And we'll learn a lot about her work in cataract refractive and corneal surgery. So Kendall, welcome.
Hi, Uday. It's such a privilege to be here with you today. So thanks so much for the invitation.
Oh, you're very welcome. So you did all your undergrad and med school training in University of Maryland and a master's degree as well. And then you came to Bascom Palmer for your residency and you stayed.
I did.
Tell us about that.
That wasn't exactly the plan. When I came down to Florida, I thought I was just coming down to do my residency, and then I was planning to return home to Maryland with the rest of my family. But one thing led to another, and I completed my residency and then stayed on as a cornea fellow. And then finally, during my fellowship, we were starting to build some satellites. Our Naples satellite was just being built, and we had a Palm Beach satellite at the time, which had been around about 8 years, and we wanted to put a satellite in Broward County in the Fort Lauderdale area. And so that was a great opportunity. And I actually had a contract to go into private practice, but then when I had this opportunity to stay on at Bascom Palmer, I was offered an opportunity to go to Wharton Business School to do a certificate program there to help with opening the satellite. And that was unfortunately a long time ago now, but that was in 2004. So we opened.
Wow, 20 years later.
That's a little embarrassing, but it's true, unfortunately. Yeah, it's exactly 20 years now.
And it's grown a lot. You've grown it from a very small place. Tell us about the path of growing from this one satellite.
Sure. So yeah, we opened for Thanksgiving week in 2004, and it was just me. We had 10 rooms, and I had Dr. Bill Smitty coming up once a month as a retina person, and I had Janet Davis coming up once a month to do uveitis. But I was there every day, and we started with about 10 patients, and I had 2 technicians, 2 front desk staff, and I ended up firing both of those technicians within a couple months. So I went down to 0 for a while there and was doing my own refractions and all that. But within like 6 weeks, I was up to about 40 patients a day. So it built really quickly and hired a bunch of people. And some of them are still with me today. So most of our staff that I hired during that first year, stayed with me. And in fact, one of my first techs has gotten her MBA. She finished her bachelor's degree, got her MBA while she was at UM, and now is my office manager. So I'm very proud that I have a couple of staff members that have been with me for 20 years. But yeah, so we've gone from just being sort of one person full time and having a few guests of other subspecialties to now having 15 doctors. And yeah, so it's really grown quite a bit. So yeah.
It's well, from one, just you solo, to now 15 doctors in the group. So obviously the number of employees has actually grown to many dozen.
Right. So, some of our employees go from one place to another, but most of them, I have about 50 that just stay with me in plantation. All of us still operate in Miami, so all the doctors kind of go back and forth, but we have 6 doctors that are primarily out of plantation. Everyone else kind of rotates up. So we usually have 5 or 6 doctors a day. So we'll have some retina. It's a little different each day, but some retina, glaucoma, cornea, optometry, scleral lenses, things like that.
So it's almost like you built basically a private practice. You started like a solo shop, and next thing you know, you've got 15 doctors, and it's a huge practice.
Yeah, we have to move around a little bit, but we don't have surgery up there. So we do have a minor procedure room, so we can do some plastics things. We can do like a rebubble if we need to, or something like that, a little excisional things. But
do you operate that in a local surgery center, or do you bring them down to Miami?
All down to Miami. So yeah, all of my surgeries are done in Miami. All my LASIK's done down there, and cross-linking is all done down there as well. So I go back and forth twice a week on an average week. So
for those like me who aren't so familiar with the exact geography of Broward County versus Dade County, et cetera, what's the distance between your location and then operating at the main mothership?
So it's like 25 miles, which is either, depending on how you drive, somewhere between 30 minutes and 2 hours. Miami traffic can be unpleasant. So sometimes that distance can take up to 2 hours on I-95, but it shouldn't take that long.
Oh, guys, it's so similar here to Los Angeles. Like I live 20 miles plus away from my clinic, and yeah, If I leave at very, very early hours, it's easy. If I leave in rush hour, it's terrible. So similar concept.
Exactly. But I really like going back and forth, honestly, despite the traffic, because it gives me an opportunity to connect with our fellows and, see my colleagues in Cornea and do any meetings I need to do. So I really like being connected to Miami. We're actually building 2 more satellites that are going to open in the next year to a year and a half. And they will have operating rooms, so they'll be closer to me. But I think I still really like going to Miami, so we'll see how that works out. But we're sprouting up satellites all over South Florida.
Maybe you could do one of these situations where they have the, in-office surgery suites, a little less than a full ASC, but maybe it's a surgical suite.
That's a great question, because I do think that's something that's the future of ophthalmology. And I think that academics a lot of times lags behind with things that are very progressive ideas like that. But, I know some of the academic centers that are building satellites are starting to think about or are incorporating office-based surgery suites. So I think it is a great idea for the future. We don't have any that we're building now, but we are building a couple ASCs. So, but I think 10 years from now, even 5 years from now, that discussion will be very different. And we'll be moving probably toward that direction around the country. Don't you think?
Yeah, I think I don't personally have an in-office surgery suite, so I use a surgery center locally. But it's very close by. Surgery center is just a couple miles away.
Yeah.
But I think you're right. There's some advantages of having it right there. And then a lot of these places can say they'll build you one for basically 1,000 square feet of space.
Yeah,
so it's really
backyard. That would be very convenient.
Right. That's not too bad.
I think that there'll be more rules and regulations to help guide us in that process. But you're right, they're kind of working through some of the kinks and reimbursement kinks and all that stuff too. So hopefully over the next few years, we'll find a way to do this. I think it's already been proven that it's safe. So now it's just finding the logistics to better do that, the in-office surgery.
Right. And I could see doing just kind of normal cases, routine cases with very cooperative patients there in the suite. And then if the patients are more complicated surgeries or less likely to be able to tolerate very mild sedation, then maybe take them to the surgery center.
No, I agree. It's just going to be a matter of us making the right decision, right? To figure out, which patients belong in which place and
right.
liabilities might be involved in that. So anyway.
Yeah, there is some comfort in having an anesthesiologist when the patient's just a little squirrely and you look over the anesthesiologist and she's like, gotcha, and just pushes a little more. You see the syringe being pushed and you're like, another patient's more relaxed, so am I. So
yes. I do kind of like just focusing on the eye and leaving the rest to them. But there have been lots of studies now that show that we can do cataract surgery, at least cataracts, without an IV, without significant sedation other than a little oral sedation. So, I'm sure that's the way we're moving. But some of these younger, tougher men who can be anxious, they probably always still need the IV. Okay,
Yeah, it can be very, very helpful. So your practice obviously grown a lot. You become very busy there. You also have a leadership role in that satellite. Tell us about that.
So I'm the medical director in Plantation. So it's kind of my little baby. So it's been really fun. I like to sort of mentor. And so in addition to mentoring our fellows, which has really been an important part of my professional life, I also like mentoring my staff and teaching them so they can partner in some of the pathways, organizing pathways of care. And, we train our staff really well. They really can be an extension of us. So it's so nice to see them sort of outgrow what I can give them. So I've had several staff members that have moved on beyond what I can provide for them, and they've gone on to take leadership positions elsewhere, which is fun to see, just like with our residents and fellows. And I know you feel the same way. It's great to see somebody succeed to the point where they're beyond what I can offer them, or even beyond what I can do, even our fellows. We have so many great fellows, but staff as well that go on to do much more than I could ever achieve. We have.
Right. Like you said, you're one who did a bachelor's degree and then an MBA, and now is running helping you run the show there. That's fantastic.
Yeah. Well, I didn't get an MBA. I got a certificate in healthcare.
No, say your employee
certificate program. But my master's is in anatomy and physiology. So I was teaching as well. So
tell us about the certificate program. What does that involve?
So that was a program where I would go up and do 2 weeks of class up at Wharton and then come back. And so it was like a program over a period of 2 years. And so it just helped me design. It was like a mini MBA. I didn't really have the time. We to do the whole MBA program, but it helped me guide my early experiences. I also took some really interesting classes at Disney, which has a management program that I completed there as well.
Interesting.
Which were really helpful. And you'd never think that Disney World could offer classes like that. But I learned so much from about how to manage people and the patient experience. And so Disney offers these management classes. And I don't know if you've ever had exposure to it, but I would definitely.
I've even heard of it. It sounds amazing.
Really? Oh my God.
What were some of the pearls you learned from it?
Full of management, and you can see if there's a course that you might be interested in, but they really they've mastered the experience and taking that experience to apply it to patients instead of the experience that you have when you're at Disney World, where people save up their whole lives and may only visit Disney World once in a lifetime. Right. And they have to make it that special and that great of an experience. If we could deliver that kind of care to all of our patients, or at least some aspect of that, I think they have a lot of things that we can learn from.
To make it more of an experience. That's like an interesting way of putting it too.
Yeah. And so they say to every person that works at Disney World, when you walk through that back door, because they all enter from a back door, so no one ever sees them entering through the front door with the people that are visiting, the guests. So everybody enters through a back door, but once they step out onto their role, they are in a role and everyone is their guests. And so, they play that role through the day. And so they kind of think of themselves as sort of actors that are providing the experience, but even the garbage collector, is cast as a role in the day of the lives of these guests. So anyway, you don't bring your baggage, the same thing about not bringing your baggage in as you work, and you separate from whatever issues you have at home or whatever, and you bring that patient's that experience. So I think it's
got me thinking when you mention this now. It's like, okay, what would be the ideal patient experience? Let's say for cataract surgery. And so what would that be, right?
I would say it would be hardly noticeable cataract surgery. So it would be probably in office, no drops, comfortable. You get up, you see well right away, go home, you're back to normal function right away. And maybe someone gives you an ice cream cone at the end. No, just kidding.
Well, yeah, my own clinic, I've tried to make the cataract surgery basically a non-event. So yeah, we're obviously only doing topical or intracameral anesthesia, short-acting agents, a little bit of mild IV sedation, and then afterwards, I don't put a patch even on the eye. I just put some sunglasses for the patient so they don't touch the eye. I stopped doing the shield and all that stuff too.
Yeah, maybe have a host too. You can have someone host the patient that would be assigned to the patient, do the call the night before, a call the night of the surgery, that kind of thing. So each patient could have their own host for the experience. I don't know. It's a whole Disney World kind of cataract surgery, I suppose. But, not to lessen the medical aspect of it, but, patient only goes through this really twice or one experience in a lifetime involving the two eyes. So, yeah.
Yeah, it just got me thinking, how else can I do this? Could I even maybe do something automated through text message or AI-based,
That might lose personal effect, though, Uday.
Yeah,
I don't know, technology is so great and AI is so great, but I do kind of worry that we might lose a little bit of the personal aspect of things. There's a fine balance there, it makes our life easier, but
it's also going to make your life easy. If let's say you knock out 25 cataracts in the morning, right? Are you going to spend 5 minutes per patient calling times 25 patients? That's
that's why you have the host. The host is not you.
The host has to do this, or maybe I could do a pre-recorded video. Hey, you just finished your surgery. Now you're at home.
Yeah.
I'm going to kind of brainstorm this with you.
Yeah, honestly. So the light adjustable lens, I've been doing that this past 6 months or so. And I have a clinic manager, Christine, who kind of hosts these patients. And she, calls them to remind them of their appointments, see how they're doing, make sure everything's going okay. And they really get attached to this person. So she makes sure the clinic flow is good so they don't wait, just really micromanages those patients. And honestly, every patient deserves that kind of care. But it made me start thinking about this kind of host experience, because we're doing some patient surveys and evaluation of the patient experience, and kind of learning a lot by watching her, with the patients and, looking at these patient evaluations to see what they really liked and what they like better than me, unfortunately, is her. So, that experience with her kind of hosting them through the process, just like I think many of my patients like my scribe better than they like me, my scribe Jackie, they know her and they feel like they have a relationship, and they bring her a little gift at Christmas time. So, I mean, that's kind of old style, a little bit of old style medicine. At the same time, we have great new technology. So how to merge the latest and greatest of our technology with a little bit of that old style personal touch can be a challenge, I think, and I agree, it's something we should talk about more at some point.
So you said the light adjustable lens, are those patients then driving down to Miami for every one of those treatments? Because there's so many treatments.
No. So I can do the treatments in my office. It's just surgery. Yeah, they go down just for the surgery day, and we do provide transportation down if they want to use our transportation. So they don't have to drive any. They just come to my office I have the LDD.
That's easy.
Office. Yeah, so it's pretty easy. No, that would be tortuous. They could never go down there for the light treatments and the lock-ins.
So many visits, right?
It can be sometimes quite a few.
But yeah, given the best patient experience, I think one of our challenges is that, there are only so many ophthalmologists. There's only so much, and we kind of have to make the whole team work cohesively, as you said, and everyone's kind of has to work to the maximum of their abilities.
I agree, and it's only becoming more of an issue. More of our patients, our population is growing. The population of people over 65 is growing. So how are we going to service all these cataract patients and this aging population? And for that matter, I read an article recently that a third of the anesthesiologists are over the age of 60 and will be retiring in the next 5 years or so. And so we're not going to have anesthesiologists. CRNAs are going to have to get a PhD level or essentially level of training beginning in 2025. So CRNAs aren't going to be readily available. And so we're going to be probably doing a lot of our own anesthesia.
Oh, wow.
Really have to rethink this whole thing. Fewer ophthalmologists and more responsibilities for the rest of the patient, potentially, as we move forward into the next decade. So, yeah, we're going to have to.
Yeah, I mean, it begs the question, like, we have to do more and more surgery, but we only can be stretched so thin. And so we have to have our team members. Again, you've got to have a CRNA, hopefully, or an anesthesiologist doing the anesthesia side, because you don't want to do that. Exactly. Then you've got to have your technicians have to be really great in clinic with you. And then someone else has to, like you say, do some follow-up phone calls.
Right.
You can't put the onus on the surgeon, because the surgeon should be doing surgery.
Right. And we don't want to downgrade the importance of what we do either, even though we can do a pretty quick cataract, but all the thought that goes into it, the process of choosing the right lens for the patient. I mean, it's not a 5 to 10 minute process. Right. As you know, it's a long thought process that goes into every selection for every lens for a patient. And so I think if cataract surgery is looked at as just the surgery itself, we have a danger of even further decreasing reimbursement, especially as we bring cataract surgery into the office, which is inevitable. But, I think we have to look at cataract surgery more than just the time we spend in the operating room.
Of course. No, it is for sure.
Raise it and getting government officials to understand that it's not just the surgical time can be tough, to have them understand the whole process that is involved in cataract surgery for the patient. Don't you think?
Right.
I worry about that a lot. So
of course, even the surgical planning, I do it myself still. I don't delegate that to anyone.
I do too. So
yeah. So how can I have someone else decide the IOL power or what I'm going to do for the astigmatism? I can't.
Right. No, I feel the same way. And honestly, you really kind of have to get to know the patient a bit. And so finding efficient ways to get to know the patient and to provide them with the education to help your partner in making this decision. I mean, it's a lot for us. And so much of it, I would say, I think at least 90% or 95% of what we do is outside of the operating room, a lot of times, especially on a complex case.
Right. It's all that post-op care too. Remember, that's all the 90 days of post-op care that's included.
That is true. Yes.
Which begs the question, like for a post-op care, you say your majority of your cataract patients, how many post-op visits do you actually need? I mean, I tend to still see post-op day one.
Right.
I'll see the patient, the other eye post-op day one, which will be a week or two later.
Mhm.
Then maybe I'll see them a month later, and that's pretty much it.
Yeah. So, traditionally, of course, we've had a 1 week post-op, and a lot of that I think went by the wayside a little bit during COVID. We started doing some virtual 1 week visits. I mean, I have an optometrist that's still seeing them because I always kind of worry a little bit about a pressure spike, maybe on a steroid during that time period. And sometimes that can get picked up at post-op week 1, something like that. So I worry a little bit, but I know a lot of people aren't doing post-op week 1 visits, and I certainly don't want to do them myself. My optometrist can do that, but I kind of wonder about the utility of that post-op week 1 visit, because I do know many of our colleagues have cut that out now. Wouldn't you say?
Right.
So
Right. So I'll do post-op day 1 on the first eye. The
yeah.
second eye surgery is usually a week later, maybe 2 weeks later. Then I'll do post-op day 1 again, and obviously check the first eye too,
Mhm.
and then bring them back at about a month time.
Yeah.
But the post-op 1 week visit used to be to make sure there's no endophthalmitis. Well, now we kind of realize that you can often present at day 9 or 10, and so you miss it on day 7.
That is true. Yeah, I think the peak is somewhere between, around day 3, but you're right. Certainly we can have some late onset, especially, dependent on the organism and all. It can be day 9 or 10. You're right. We can't just see them every day. But
Well, I kind of look at it like, okay, what's the possible problem you could have on that post-op visit? And then what's my intervention? Like post-op day 1, I totally get, because you could have a retained lens fragment, you could have a leak from the incision, you could have a slightly dislocated lens, let's say in a complicated case. You could have a tremendous amount of AC reaction. You could have something like this going on.
right. And I think most of those could be caught on a virtual visit, or a phone call. The only one that I really think, because endophthalmitis, they'd have pain, they have decreased vision, they would report that, at the 1 week virtual visit. But, the pressure spike, again, could be asymptomatic,
Yeah, no, that's a good point. But I mean, I definitely see utility in post-op day 1, and I still enjoy doing it. But who doesn't love post-op day 1? The patient comes in and says, "Oh my God, thank you, the vision's so amazing." Who doesn't love that praise?
Yeah, I even had to take all 3 of my kids in to do some post-op day 1 visits with me, during their summer extra hours for school, just so I could kind of be a hero every once in a while too.
Right.
It's hard to be a hero to teenagers, but when they were younger, it was kind of fun. So
Post-op day 1, post-op week 1, I've kind of largely think it's really not as critical.
Right.
And then post-op month 1, they can come back. You can do a full dilated exam, but even that's no guarantee. Let's say you got someone who's a high axial myope, 30 millimeter axial length. You do beautiful surgery, everything looks great. On post-op month 1, you dilate them up and everything. The retina perfectly looks fine. But you and I both know you can still have continuing shifting of the vitreous and tugging on the vitreous base a month or 2 or 3 or 4 months later, and then they can have a break in the retina.
Of course. Yeah. I mean, I guess that comes into the education component here. I mean, the patient does have to be educated as to what would be an emergency, because they can't move into your office during the entire post-op period. So, continue and advising them, when should you present as an emergency.
Right. I think that some of the onus has to be on the patient too, because like you said, you can't see them every day post-op. You can't say, what if endophthalmitis post-op day 3 or day 4 or 5? Let me just see you every single day in my clinic. That doesn't make any sense.
Right.
So the onus has to be on the patient.
Right. So I think that's where some of the educational materials with the post-op materials, differentiating what's normal versus what's not. But I do think virtual visits and phone calls can do a lot of this, as an extension of our time in office. Because as we said, population is increasing, we have to be more efficient. We have to find ways to do things, with the use of AI or use of virtual care, the use of physician extenders. I mean, there's so many ways that, and things that we're going to have to use to take care of all these patients, right?
Yeah. So in the U.S. numbers were about 4 million cataracts last year in 2023.
And you did of them, right?
No, I actually want to work less, not more, to be very frank. And that's honestly, I'm part of the problem. I'm part of the problem where it's, after age 50, I'm just kind of balancing out. Do I want to keep trading, time and happiness for, more revenue? And I don't. I'm okay.
Yeah, life is only so long, right?
Right.
Priorities kind of change and your perspective changes over time. So I certainly understand, we only have so much time, and I think things become more meaningful as you watch your kids grow up and realize, oh my goodness, I don't have any little kids anymore. And now you're on to the next stage of a different sort of view and appreciation of things. But I agree, we have to value our own lives as well. So a lot of times we get so wrapped up in work and what we do
Right.
at work, it's easy to forget that there's a life outside of that. I mean, at times.
Our CataractCoach podcast tends to skew to younger listeners. So I think more than half our audience is 30s and 40s, which is great because there's so many good pearls to learn here. But let me tell those young ophthalmologists, we need you to get cranking on the volume.
Is that what you were going to tell them?
You got to get cranking on that volume, do more and more cases because you have a different outlook. When you're 35 and in practice, you just want to crank.
Yes, that is true.
But then, fast forward 2 decades, you're like, okay, I'd had a really great run. I learned a lot of things. Let me just, take it a little easier now. There's a difference. There's a difference between the beginning of your career, mid-career, and kind of, end of your career.
But that's such a fun time, though, to, build a practice, learn new things. I mean, be excited about everything and embrace new opportunities. So you never know what's going to come your way, right? I mean, who would have thought, like we were talking about before, how CataractCoach has been so successful? How long ago did you start CataractCoach?
Well, I've always had videos online for 20 years, but I started doing a video every single day in early 2018.
2018. So who would have thought then that it would be this empire and we'd be sitting here today, right?
Well, that's the hard. I mean, the hard part was committing.
I knew. I mean, you probably didn't know. But I knew it.
No, I had no idea. But I put the commitment in, like, I will make a video every single day. And so I haven't missed a day in 2,100 something days.
Yeah. And I think it's nice to be dedicated to something like that. So I think every person starting out in the career can find like a little niche. And they kind of teach that to us in academics, to find your niche and then kind of dedicate to that and still do everything else, but find something that you're really passionate about and really become an expert in that little thing. And especially if you want to get involved with industry, which is amazing, develop new products or, change the course of what we're doing in ophthalmology, but to have an area of special interest that you become, known for is really kind of a fun thing. Whether you're an ophthalmologist or whatever you are, I think it's kind of nice. I try to get my staff to feel the same way. So I kind of assign them a special task in the office. So one person might be the dry eye technician, does all the dry eye stuff, and I have other techs that are the LAL specialist, and they like being sort of empowered, I think, as we all do. You
can always tell the tech who specializes in the dry eye because the lissamine green stain on the fingertips.
Yeah, great.
I think that's an important thing to choose something that you really are passionate about and really have a one area of focus. Yeah. And then you also mentioned how you got involved with, with industry, because now you have a deep expertise in one thing, and that does attract industry to work with you. I think ophthalmology is an unusual field where industry works very closely with the clinicians and surgeons.
Right.
And it's probably my number one question from young people, which I'll leave you with, is how do they get involved? A young ophthalmologist, how does he or she get involved in this?
So my answer to that would be find mentors, find more than one person that you would like to emulate and say, oh, I'm interested in working with industry in this way, and I'd like to do what this person does. And then introduce yourself, show your enthusiasm and learn about what they've done. And they'll make introductions, because all of us love mentoring younger ophthalmologists, and that's an opportunity to be introduced to industry. So find someone whose interests align with yours and ask them how they did it. Ask them to make introductions, volunteer, to help on a talk or help on a project. So everyone loves a good volunteer, right? And you can share the enthusiasm for what that person's doing, and it creates a bond, and then you move to the next level. And industry always embraces that enthusiasm as well. So, those connections are really key.
That's great advice. Now, how about getting on the podium, like in a meeting? I love to hear your lectures, and I've heard you speak on, dozens of meetings, but how do you get on the podium? A young person.
As a young person, oh gosh, I forget now. No, I'm just kidding. So again, make yourself knowledgeable in a particular area. Let people know that you're, enthusiastic about something. Volunteer. If you want to go to a certain meeting, find out who's involved in that meeting, who's on on the organizing committee for that meeting and introduce yourself and tell them, I really liked your talk on this, and I've been doing that too, and I've taken a little different approach to it. And I'd like to speak, you just say outright, I'd like to do this, I'd like to do that. And we like to know, we like when people are forward, right?
I love it. I think it's great advice. Another good pearl I have is if you want to speak at a meeting, see who are the meeting kind of section organizers or section leaders, and email them with a very specific list of, here, I would love to participate in your session. Here are 5 talks that I could do, and have them very clearly delineated, like, and appropriate to the format of that meeting. So let's say that session is going to be mini 7-minute talks.
Mm-hmm.
I can do a 7-minute talk on challenges with a posterior polar cataract and open capsule. I can do a challenging, how do I manage a phaco wound burn?
Right.
Or how do I manage, irregular astigmatism, and whatever it is, but have a list of specific topics of talks you can actually give, and then submit those. Because then when they put the program together, it's like, we have a section on this. Ooh, one of those talks would fit in real nicely right there.
Right. Oh, I agree. Those are great ideas.
Yeah. And then also, don't go over time. If you're given a 7-minute slot to speak, you cannot speak for 8 minutes or 9 minutes. It has to be at a maximum 7. So go in there and
probably to go under. Okay, you can
Right.
always go under, just don't go over. Less slides is better, and I've had to learn that through the years too. But moderators don't like having to control people.
Right. No, for sure. Never go over your time is probably a key point. And then if you're a young ophthalmologist, you can understand you don't need to do PowerPoint slides anymore. Incorporate your PowerPoint slides into a single MPEG video file. So every lecture I give, if I'm invited to give a 7-minute talk, I have a video file that's 6 minutes and 45 seconds. And all I do is I just hit play and I start talking.
Yeah, talks I think are much better if you're telling a story. And I think a lot of your videos are stories.
Right.
And I think all talks are better told as a story, so.
I still have slides. I'll still have slides, but they'll be within the video file.
Right. Then tell your story and make your point. Right. And I would say less slides is always better. And nobody's going to remember the minutia anyway. They're going to remember the final endpoint and your cool video. Of course, they'll remember your cool video.
Right. That's people obviously learn the video stuff. But no, that's all great points. I definitely encourage the young ophthalmologists, please get involved. It's really fun stuff. You make great friends, and all over the world, even not just in the US, all over the world, you have great friends.
Yeah, we're pretty lucky to be in ophthalmology. I don't know that all fields are like this, but
ophthalmology is an amazing field. We got very lucky here.
I agree.
So we're very lucky to be in ophthalmology. We get friends from kind of all over the world. It's really an amazing kind of cohesive field. I'm not sure other specialties are as lucky.
Yeah, I think if I were just stuck as a solo practitioner in my little hole in the corner and I didn't go to meetings or didn't interact with colleagues or didn't interact with industry, I think that would be a tough way to practice. So I think a lot of what gives meaning to what we do is going to meetings, learning from each other, making these collaborations, teaching and mentoring. And, we certainly have fun times, like you said, around the world, and lecturing and teaching helps us to do that. We have these great travels where we can learn from each other and make friends. Otherwise, I would never know you from the other side of the country, right?
Right. No, it's an amazing thing. So definitely for young people, get involved, speak at the meetings, contribute to the future of our field. That's all neat. What new things do you think are coming down the road for our field?
I think, as always, new and better IOLs. So I'm always excited about, maintaining the quality of vision, but increasing range. So the priorities in that order. So we've got great lenses, some of which will be released in the next couple months, and some technology over the next several years. And I love the idea of post-operative adjustments. So the LAL has been really fun, but I think that in the future we'll have other ways to adjust lenses, even beyond the immediate post-op period. So that's exciting. And getting beyond phaco, using less energy in our cataract surgery. I mean, again, we're so lucky that technology and industry has helped us to do better cataract surgery and help patients recover faster. And and I do think, it's interesting to look at what might be happening in 10 years. I do hope we have a truly accommodating lens and can really approach the youthful lens. I think that would be great. Injection of endothelial cells and the end of lamellar keratoplasty potentially. You know, there are lots of exciting things, and it keeps evolving.
That'd be really neat. Yeah. So like for Fuchs dystrophy, instead of having to do a DMEC, to be able to just inject endothelial cells would be so cool.
Yes. Yeah. Very cool things, of course.
That'll be what. Yeah, and an accommodating lens, of course, everyone wants that. That's like the holy grail.
Right.
And I think we're hopefully moving that way. There, I'm also involved with a company that does robotic cataract surgery. Oh my goodness.
Yeah. Interesting stuff.
Unbelievable. It's automated.
I hope they still need us someday, Uday.
Well, at least for now, at least the robot's learning how to do routine cataract surgery, not the complicated ones, not the difficult ones.
Yeah, the robot's going to do the surgery, and the AI is going to do all the post-op visits, and maybe figure out which lens is best.
So what do we just stay at home and supervise it from a laptop?
I guess so. Yeah. No, I'm working with a company that's creating a simulator for different lenses for cataract surgery, so the patient can experience it.
Oh, that's neat.
So, you know, again, using that technology, and a lot of AI can go into that as well, but helping us to make the very best decision for the patient, so we never make a bad choice as far as the lens for cataract surgery. That would be perfect.
Right. Well, I had a case on CataractCoach recently where the video was submitted to me from elsewhere in the U.S. where a patient went under to have a bilateral IOL exchange because the patient had a, quote, multifocal misery, unquote.
Oh my goodness, that sounds like a nightmare. I don't even like thinking.
What's tough? It's like, you know, how do you choose the right patient for a multifocal or trifocal lens? That's like, there's a bit of an art in there. I wish there was a more concrete or definitive way of doing it. Yeah,
I do too. I mean, there's so many little things that we look at, and we can still look at every little thing and think we got it just right, and this is the perfect candidate. And occasionally we can be wrong, which is a little bit scary. So I think that's what holds us back with premium technology. I love all the premium technology, but in a small fraction of cases, sometimes our decision wasn't just right. And, you know, it can affect a person's life. So it is a big responsibility that we take, you know, and having more confidence and having tools to help us be more confident with making those decisions.
Right.
Really, really key. And we're thankful for industry for helping us to develop tools to be able to do that better and better.
Yeah, because one of the catches is like you'll see a patient in your clinic who got, let's say, trifocal lens and is so thrilled, so amazed.
Right, I know.
And you say, "What about? Do you see anything nighttime glare?" It's hardly anything. It's nothing. I love it. It's the best thing I ever did.
Right.
But in the same clinic day, I can see a post-op patient who had trifocal lenses says, "Gosh, the quality of vision is just not good. I just don't like this." So how can that be?
So my mom has trifocal lenses, and she's super happy and never has said once that she has glare or halo. Right. So I don't even really talk about it. But I saw a 40-year-old gentleman yesterday who had a trifocal lens in one eye. He had a traumatic cataract, and I didn't do his surgery. And he was so happy, you know, and he's a -4 and does not have any cataract in the other eye, and was thinking about doing something with the other eye. But he's so happy with his multifocal lens. And I said, "Oh, you know, how is your night driving?" He's like, "Well, I have a lot of glare and halos." And I'm like, "But you're happy?" And he's like, "I'm so happy." And I was like, but he's like, "I knew I was going to have glare and halos in that eye, you know," but he's like, he had a traumatic cataract and couldn't see anything at all out of that eye. And he knew he was going to have glare and halos, but he was so happy. And I would think a 40-year-old patient is at risk for being really unhappy with diffractive.
Right, especially because the other eye is essentially normal other than being myopic.
Yes, and I would have had a hard time thinking, well, that patient's going to love this diffractive lens at 40 years old. So I don't know that I would have put that lens in there, but my colleague did. And the patient is so happy, despite, he said, "Yeah, I have like really large halos."
So should we be doing more of a personality questionnaire or personality biopsy ahead of surgery? Is that part of it?
But I mean, I think part of what the surgeon did that was so great was really informing the patient. And the patient is not wearing any glasses, although he's wearing a contact lens in the eye that I'm addressing now. But he's not wearing any glasses. He can get by. You know, that lens sees well at all distances. And but now he has to deal with his dominant eye. So
what are you going to do for that one, LASIK?
So we talked about LASIK, but he didn't want to lose his near vision because sometimes he'll take his contact lens off, and he's a -4 and he really likes holding things really close. And so he didn't want to do, you know, distance LASIK, but he is a good candidate for that. He wasn't ready to put a multifocal lens in his dominant eye. So we're seeing each other in 6 months, Uday.
There you go. Maybe.
I decided to continue his contact lens, which he wears. Just
Right.
he's doing fine with it. So, but we really have to get to know these patients to make that decision. He's going to wait for new technology or see how things go over time. But
reasonable approach. Yeah, we're the contact for now until he's 40, so they wait till he's like 47, 48, more presbyopic.
Exactly. That's what I told him. I said, things are going to start to change for you over the next couple of years. So we're going to wait and see.
Yeah, I just wonder because I just have that same issue in my clinic where some patients are so thrilled and amazed by it and recommend it to all their friends, and other patients are like, it's okay.
Yeah. Well, what lens would you put in my 40-year-old gentleman who's a -4?
Well, I think if he has a trifocal in the other eye, that's actually pretty reasonable near vision already, because that's probably
he's not
diopter.
No, because it's his focal points out. He's like, he likes the two eyes together, because like when he lays in bed at night, he takes his contact out and he prefers to read with that near eye.
That's really close. -4, so it's a fourth of a meter, 25 centimeters. That's 10 inches. That's pretty close reading. I don't know if we get
that really high quality near.
Yeah, let's. I'm a -2. I get it. Believe me, I like myopia too. But maybe the best answer really is for your patient just to wear a contact for now.
Yeah. So he made the decision himself. We went through the thing, but in order to get him to the point of making a temporary decision, it took quite a bit of time, as you can imagine.
Why do you think the U.S. refractive market, let's say for corneal refractive surgery, or even fake IOLs, is different than the rest of the world? Like in the rest of the world, there's a lot more SMILE, and the U.S. has a lot more LASIK. And then in overseas, there's a lot more adoption of fake IOLs.
Of course, but fake IOL is a really good one, like Evo. It hasn't been around that long in the U.S. and they've had it quite some time elsewhere. So, I think that's going to continue to increase. There's been so much talk and adoption of that over the last 6 months or so. Even it just keeps increasing and increasing. So I think patients aren't really exposed to Evo. They're not familiar with fake IOLs. They only hear about
a lot of direct-to-consumer now stuff. So I'm like, even on the internet, maybe it's because I have so many Google searches for ophthalmology-related things. I see ads all the time for various celebrities who've had Evo ICL.
Yeah, but don't you think it's much more over the last year or so? So
yeah, for sure, you're right.
2 or 3 years as compared to Asia or in Europe where they do quite a few.
Right. No, I think you're right. I think
we're behind.
No, but I think it's different though. In a nascent market, let's say you have a market that's new to refractive surgery. To do LASIK, state-of-the-art LASIK, you need to buy 2 lasers, a femtosecond laser to make your flap and an excimer laser for the ablation.
Right.
If you just do a SMILE type procedure, a lenticular procedure, now you only have to buy 1 laser. And you have very few hyperopic patients. Your patients, let's say in that market, are almost all myopic. So you can have 1 laser. Or you can set up a clinic and just do fake IOLs and have to buy no lasers.
Right.
Kind of the cost of entry for admission is less for these procedures.
Yeah, I mean, I do think over the next couple of years, we're going to see a shift in that direction as patients become more educated and more aware of the different refractive options. So, we're just a few years behind.
Yeah, no, I think it's neat. I think the Evo ICL is a neat procedure, and especially if you can do lower powers for patients. And what I like the most, obviously, is that when it comes time for the cataract surgery down the road, it's very easy. Calcs are simple. Explant the lens in a second.
And I think that concept of reversibility is really going to appeal to patients. I think one of the things that has held that technology back, though, is the cost differential.
Yeah.
So in most places, doing LASIK is less expensive than doing a phakic IOL. So that kind of is a limiting factor. But I think patients understanding the reversibility, you're not taking away any tissue. So certainly there are benefits there.
No, I think you're right. I think cost is probably the biggest issue in our clinics. And so if we can kind of get over that hurdle, I think it'll be a big help for the patients. You'll get more adoption.
Certainly when you start doing the surgery in your office and do the bilateral same day in the next room, that can get over part of that hurdle as well.
Right.
Cost issue for a patient that's getting an Evo ICL. So.
Right. I've seen some surgeons doing these fake IOLs just under the oculars of their excimer laser in the clinic. So
come do them on the sidewalk outside. No, I'm just kidding.
I obviously prefer to do them in the surgery center because I like the sedation on board, you know?
Yeah. No, obviously, we need to follow certain parameters, the safety parameters and all that. I was just joking there, but making it easier and more cost effective
Well, I've got to ask you about one thing. I'm not a cornea specialist. You are. I got to ask you a question about a thing I saw on my Instagram.
On
I saw
Instagram.
this
Okay.
eye color change
Oh, geez.
by using it's not the one where they're implanting this artificial
No,
iris.
laser.
The patient's getting uveitis and glaucoma and cataracts and it's not that.
Yeah.
What the surgeon's using is using a femtosecond laser. They're using it to make a corneal flap. And then as the femtosecond laser flap is being made, it goes from the outside in concentric circles. They stop it. So you have a central, let's say 4 millimeter zone that's uncut. And then the surgeon is putting tattoo pigment in the stroma.
Oh my goodness. I have not seen that, Uday.
It was on my Instagram.
I'm going to have to look that up.
Keratopigmentation, basically. Femtosecond laser, keratopigmentation. It's like all the rage. It's interesting. The one I saw was a video of a vitreoretinal surgeon who does this now.
Oh my goodness. I just wonder if they would get DLK or anything from the pigment in the interface.
Well, also, how do you do the future cataract surgery when you can't, now have a 4 millimeter view through the cornea?
I wonder how opaque it is, though. Maybe it's not completely opaque, that you could maybe see through the pigment, or the pigment, has separations between it. Because, you'd want to show that, just like there's studies that show that with Apthera, that you can still get a good view of the retina. And we have good data to support that. Right. But I wonder what data there is to support view to the back of the eye, tolerance of the pigment and the interface and things like that. I'm going to have to look that up, Uday.
Yeah, look it up. It's femtosecond laser keratopigmentation.
Should I look it up on PubMed or look it up on Instagram? I can't decide.
You're probably better off on Instagram. But the problem is all the Instagram ones are like the external views, nothing slit lamp. There's no slit lamp views. You're not seeing it too far up close. So it's hard to say.
That's really interesting, though. Concerning.
The things people do. I know Miami's a lot like Los Angeles in terms of cosmetic stuff, and plastic surgery is huge in Miami and LA.
Yeah, no, it could catch on here.
Well, I just wouldn't do it to my own eye. That's the problem. Is I can't offer this because I'd never do it to my own eye.
Yeah, no, I'd have to agree there. I don't want that in my own eye or any of my family members. That's a very good point, too.
But neat stuff. Anyway, Kendall, what a pleasure talking to you. I learned so much from you. Always fun to hang out.
So much from you. So
yeah, I love the thought process here. I love the patient experience. I want to try to implement that in my practice, do a better experience type thing. I'll have to look into the Disney thing. I wasn't even aware of that. That's a great idea, though.
Yeah, they actually even came down to Bascom Palmer to do some courses with our staff. So
wow.
So everyone at the administrator level and the supervisor level went to Disney, and we took courses there several times. And then they do a program where they'll come into your practice and they'll train your staff. It's not the whole program, but it's a nice little staff program.
Nice. Did you get to go on a few rides too, or not?
Well, when I went up there, yes. They don't bring the rides. If you have them come to your office, they do not bring the rides with them. You actually have to go to Disney for that part.
But I think we're getting there. I think we're getting there with a better patient experience. I'm going to really kind of brainstorm this for a while, see what I can do different in my own practice. That's a great idea.
Yeah.
So, cool. Well, I look forward to seeing you soon. Hopefully, probably the ASCRS in Boston coming up.
Yeah, sounds great.
And I want to thank you again for doing this podcast. Just such a pleasure to chat with you.
Yeah, thanks for the invitation, Uday. Lots of fun.
All right, my pleasure. I want to remind our viewers and listeners, new podcast every single week on Amazon, Apple, Spotify, Google, YouTube, wherever you find your podcast. And plus, of course, check out CataractCoach.com for our daily video of the day. 2,100 and something videos and still growing.